Assalamu alaikum. It's 10 a.m. and we're going to start the program. A very good morning to all of us who have joined us today for the PSH webinar series. And in our 13th webinar today, we will discuss the latest updates on hemophilia. In Pakistan, hemophilia is one of the most common inherited bleeding disorders. The World Federation of Haemophilia reported that over 200,000 patients from 115 countries were diagnosed with hemophilia in 2019, of which over 2,000 patients were identified from Pakistan. And like every other disease in our country, the true incidence of this disease remains unknown. This could be attributed to the level of consanguinity, which is prevalent, the limited diagnostic facilities, and of course, the poor awareness of the disease. The treatment of hemophilia in the last decade has undergone major changes with the introduction of newer treatment modalities. Like I said, the treatment of hemophilia in the last decade has undergone major changes with the introduction of new treatment modalities. And our webinar will be focused on the same. We will have 4 presentations and we will take questions after the presentations. We begin the webinar with our first talk by Dr. Ayisha Imran, consultant hematologist at Chughtai Lab, and she will speak on the approach to a patient with hemophilia. Dr. Ayisha, the floor is yours.
Thank you so much. I'll be sharing the presentation. It is just a basic how to go about when we have a patient with hemophilia. So as this is a royal disease and it was discovered when Queen Victoria was found to be a carrier and his son had that disease and which affected him severely by bleeding and debilitating joint bleeds. So this is what I tell my patients, that you have a royal disease and this is nothing to be scared of, because they were the ones who got the disease first. So next. So these are the queens and the princesses. So hemophilia, as we know, is an X-linked recessive disorder, and so it is transmitted from the females to the male children. And this is 70% of these hemophilia patients have inherited this are X-linked, and 30% would have spontaneous mutations, and some of them will complicate the treatment, as Shabneez has told, that they will develop inhibitors against those factors which were transfused, and rarely hemophilia can be acquired by forming autoantibodies against factor VIII. Hemophilia B has a similar inheritance pattern as hemophilia A, but there is a deficiency of factor IX and is seen in about 20% of hemophilia cases. As we go back to the coagulation cascade, how this happens is that on the surface of the phospholipid membrane formed by the activated platelets, there is the DNase complex is formed which leads to the formation of prothrombinase complex and then thrombin generation. In cases of factor 8 or 9 deficiency, obviously the DNase complex will not form and there will be no thrombin generation, and the patient will obviously continue to bleed. Next. So this is a factor 8 gene, and some of the common genetic defects that can be found, like intron 22 inversion, intron 1 inversions, which cause large deletions in the factor 8 gene, and this would lead to the defect that we see in many of the hemophilia patients. Although these are not the only defects, there are many other, but sometimes what we have seen in our population as these are the common ones, and they cause severe hemophilia. These patients would present with uncontrolled bleeding after either minor trauma or as a spontaneous bleeding tendency. The most common presentation would be a recurrent joint bleed, and that would lead to target joint formations. Some would have muscle hematomas, and severe bleeding tendencies may be seen in severe hemophilia patients like intracranial hemorrhages, GI bleeds, and hematuриas. This is a picture for a joint bleed with a target joint and an X-ray showing an joint arthropathy. So these are the complications that we will see over time with recurrent joint bleeds in patients with hemophilia. So the symptoms that the patients would present would usually correlate with the degree of the residual factor activity, which means that the severe the hemophilia, the more symptoms the patient will have, and the tendency to bleed will be more in patients with severe hemophilia as compared to those with more residual factor, mild hemophilia patients. And they will usually present as this table shows that the age of onset in patients with severe hemophilia would be much earlier as compared to those who have mild or moderate hemophilia, and the tendency for severe hemophilia would be like intracranial bleeds would be seen more in severe hemophilia patients as compared to the mild hemophilia patients. Now coming on to the diagnosis of these patients. So there are three principles for diagnosis of these patients. The basic understanding is how the clinical presentation of patients with hemophilia would be, the clinical history, the family history, and most of the patients, like 80% of these patients, would be diagnosed on the basis of history alone. And then the next step would be to use screening tests, not just jumping onto the factor assays and a long battery of tests. We would just have to first use the screening assays like prothrombin time and APTT and platelet function assessment by using what we use here is most commonly bleeding time, because PF100 is not available, and it is very, if it is there, it is very costly as compared to bleeding time. So it is more commonly used. And I must say that it is not that bad a test. So confirming the diagnosis would require factor assays and other appropriate investigations for the diagnosis of bleeding disorder. Who will need the screening test would be the patients with the history of family history of bleeding disorders, who are active carriers, and if there is a bleeding tendency after some insult like even tooth extraction, surgery, or trauma. And those who would have these, those who are confirmed carriers and are planning for future pregnancies, the genetic testing can be offered by chorionic villus sampling, and those with the history of, and also in those patients with the history of hemophilia. This is very important how to go about when there is a patient with a suspicion of bleeding disorder, and this is the basic. I must say this is the basic method to diagnose a patient, not just test, because a good history will lead you to the diagnosis. And some of the questions that you might need to ask would be that if there is any bleeding after trauma, and that extent of bleed should be assessed. If it is after a minor trauma or big surgeries, is what type of bleeding is seen? Is it a soft tissue bleed or a joint bleed? And if there is any bruising or petechiae, and even and where they are located. Are they extensive? Are they large? And these patients sometimes would give you big bleeding histories, and sometimes there is no evidence that you would see those patients. It is not uncommon that we see those patients with psychological, psychiatric bleeding disorders like Munchausen's and Gardner-Diamond syndromes, and they will make you just crazy by giving a history of excessive severe bleedings. And I know everyone has seen those patients in their OPDs. So there would be, especially the females, when they say there is menorrhagia and you cannot estimate that extent of bleed. If epistaxis or menorrhagia, do they require any transfusions or iron therapy? This is what I do. I just go back to their hemoglobin levels and see if there is actually severe bleeding tendency. And we know that whenever there is the severe bleeding tendency, the hemoglobin usually would fall. And obviously family history, if any direct relative has a tendency to bleed or not. Next. You must also see if there is another associated bleeding disorder when there is a tendency to bleed, like any liver disease, any connective tissue disorder, myeloproliferative disorders, amyloidosis, and history of drug intake. This is I've used this tool, the ISTH bleeding assessment tool. It is a very good assessment of real bleeders, and this could next please. This will help you grade the bleeding disorder, and at the end of the score, you have a number, and you will see that bleeding with the patients with bleeding disorder would have a higher bleeding score. Next. Then coming on to the diagnosis. So obviously, the first step for a bleeding disorder would be complete blood count. A low hemoglobin would point out that the patient is correct, that he has a bleeding disorder, and the platelet count should be assessed on CBC. Then the screening coagulation tests like PT and APTT. In cases of hemophilia patients, it would be the APTT would be prolonged at least 2 to 3 times. The bleeding time would be normal. Then we would do mixing studies using normal plasma, pool plasma, and then factor SS to assess the grade and to grade the deficiency. If it is mild, then it is usually it is between 6 and 49%. And then moderate deficiency would be between 1 and 5%, and severe deficiency is less than 5%. And genetic analysis if there is a requirement for carrier screening. What WFH recommends that this is what we find that many a times we label hemophilia patients as mild or severe would depend on what type of sample that we receive in our labs. The sample should be in 3.2% trisodium citrate and it should be transported at 18 to 25 degrees during the whole process, and should reach the lab within 4 hours, and it should be run within that time. And if not, then it should be separated and stored at -35, and that can be stored for at least 2 weeks. The screening test, as I've told, that bleeding PT and APTT would be used for screening, and the bleeding time, as it lacks specificity, it is usually is worldwide not recommended, but we are using it. Next. This is how we interpret the screening test, that in cases of hemophilia A and B, the APTT would be prolonged, platelet count would be normal, and PT would be normal, and so is the bleeding time. Next. Mixing studies, we would do mixing studies by using normal pool plasma, and if there is and then immediately, and then after incubation for 2 hours at 37 degrees to rule out any inhibitors. Sometimes acquired hemophilia would show normal, would show correction with normal pool plasma in immediate mix, and then delayed when after 2 hours it would show prolongation of APTT. So there are 3 types of factor assays that are done, but one stage is most widely used, and then chromogenic. The main issue is that we might miss mild factor deficiencies in one stage assay, and overdiagnose patients who are normal in some cases as mild hemophilia. So in cases of one stage, next. In one stage assay, we use dilutions of the normal patient plasma, and then against known deficient factor deficient plasma, and calculate the factor level accordingly by the standard curve drawn by the calibrated plasma supplied by the supplier, and draw a calibration curve, and against that we calculate the factor levels in the patient's plasma. Next. So this is 2-stage where there is generation of factor 8 and factor 10, and then in the second stage there is a generation of thrombin. Next. So in cases of chromogenic assay, we use a chromogenic factor 10 substrate, and this would generate color. Next. In some cases of this, so next, just pass on to the next. Sometimes we have, sorry, just wait, Natasha, go back. So in some cases of von Willebrand, when it is a Normandy type, it will mimic factor 8. So it is very important that we have both. We sometimes would need to do both von Willebrand factor levels and factor 8 to see if it is not von Willebrand. They will be normal in both in Normandy type. So inhibitor screening would be required when there is a case of acquired hemophilia, and as we've seen that they would be, the inhibitors would sometimes be immediately acting inhibitors and time dependent, depending upon the kinetics of the inhibitor, and that would be done by immediately identifying inhibitors and immediately mix with normal plasma, and after 120 minutes of incubation at 37 degrees. So for confirmation of inhibitor, next. For confirmation of inhibitor and calculation of titer, we will require to do Bethesda assay, and Nijmegen modification of Bethesda is used to is a better method as compared to classical Bethesda assay, as we will be able to diagnose some mild inhibitor and low titer inhibitors in Nijmegen modified Bethesda. There was a patient that I got. He was using this steroids and infusions along with factor. I just asked, why are you using factor with the steroid infusions? So he comes that I was sometimes diagnosed as having inhibitor. So if he has inhibitor, either he should use a higher factor 8 if it is a low titer, or a bypass agent. So this patient, when I just did his mixing studies and diluted that plasma in cases when I did his classical Vedestra, I could not pick up the inhibitor. And when I did this modification on that sample, his titer was about 0.6 units, and that means that it was being missed on classical assay. So next. Some patients would require genetic testing, especially this. I've told that there are patients that come for carrier detection, the female especially who want to have children and they have family history of hemophilia, they have brothers with hemophilia, so they will come up with you and ask for genetic testing. Obviously, the most common defects with severe hemophilia, as it is more common in our setup, would they have intron 22 and intron 1 inversions, but we might need next gene sequencing and for those who do not have these defects. Next. This is just some scenario for you to see how we proceed. There's a 23-year-old primary gravida who gave birth to a male baby who had a normal birth weight and head circumference, and the baby was just smaller for gestational age. And this baby was given 1 milligram of vitamin K, and there were no feeding issues. The blood was drawn, and for blood count and typing, everything turned out normal. Initially, the platelet count was low, but when repeated, was found to be normal. On the second day, he had a circumcision done, and there was severe bleeding. And over the next 5 hours, the bleeding worsened, and they had to be transferred to intensive care. Now, I hope everyone would be knowing how to proceed with the diagnosis. Obviously, by screening first, and then accordingly managing this patient, because circumcisional bleed was significant, and this patient should be investigated for a bleeding disorder. Thank you so much.
Thank you so much, Dr. Ayisha. That was a very well summarized presentation and diagnostic facilities available to diagnose these patients. And Dr. Anila is going to talk on the same topic, which is principles of hemophilia care.
Assalamualaikum and good morning, everyone. So this is my disclosure statement. I have nothing to disclose. Then there are, because my topic is about the general principles of how do we care about the hemophiliac patients, and there are multiple aspects of how we can improve their quality of life, and it includes a number of important aspects that needs to be looked and further worked upon, and I will take them one by one. So a shortage of well-trained healthcare workers, especially including the physicians, have been identified as one of the most important issue of concern among the developing countries. And I think knowledge is the first step in addressing deficiencies in hemophilia care, especially in our country. And I think webinars that are being conducted at different forums, different platforms are a good source of regularly updating our knowledge and training regarding the hemophiliac patients. And it does not only include the physicians, but the lab technologists and the general hair care workers as well. And therefore, we also need special programs for increasing the awareness about the management of hemophilia among all the healthcare workers and health planners. And and there is another important aspect is about the research. Support for appropriate research program to create evidence-based management relevant to the local practices is recommended. So what I did was I tried to look how much research has been going on in our country, and when I put these terminologies, hemophilia in Pakistan in PubMed, it showed me 65 research papers, but most of them were case series and descriptive observation studies. Considering the number of hemophiliacs we have in our country, I think we need much more in this respect. In 20, if you can see here, local guidelines were established by all the hematologists from different parts of the Pakistan, and we have came up with a guidelines about the laboratory diagnosis of congenital disorders in Pakistan that was published in 2012. And because these guidelines documented how we can diagnose these disorders in a cost-effective manner, because most of us follow the international guidelines, but considering our setup, the cost restraint, I think the need for the laboratory, the need for the local guidelines is very important, and we already had one for the laboratory diagnosis, and I think we will come up with the management and prophylactic guidelines as well. So the next step is the enhanced lab diagnostic facility. We need to have a good number of diagnostic labs that offer the hemostatic testing so that these patients can be easily diagnosed. And the very important aspect of lab diagnostic facility is well-trained lab staff, because the coagulation or hemostasis is a very sensitive area of the hematology that requires a special training. And obviously, the lab reagents are also very important. And not only the provision of the test is going to solve the problem, but the provision of the quality control or quality assured diagnostic services is important. And each laboratory diagnostic that are offering the hemostatic testing should take part in the external quality assessment program for the reliability of their results. So this is information has already been shared by Dr. Natasha in the intro, that the global survey that was conducted by the World Federation of Haemophilia over a span of 10 years showed that the number of the hemophiliacs and other bleeding disorders are increasing rapidly. And this is not even double, but I think this is 3 times of what have been reported in 1999 and what have been reported in 2018. And same is the case with the patients who were increasingly diagnosed with von Willebrand disease and other bleeding disorder, and that it showed that there was almost a 200% increase in the number of the patients who were diagnosed with these bleeding disorders. So in this report, the World Federation Haemophilia reported almost 195,000 hemophiliac patients, and from which almost 2,200 patients were from Pakistan. And as Dr. Natasha has already mentioned, that the incidence could be much higher, because we know the diagnostic facilities are not very readily available in Pakistan, and a number of patients never seek the medical advice. So this figure could be very high. But this is a very promising thing that I find out, that in 2003 Pakistan had only 3 operational hemophilia treatment centers, which has been increased to 18 by 2010, and must have been increased by now in 2022. This is a study that was reported by a non-for-profit organization in Pakistan, and it reflects the availability of the diagnostic testing. Although the number of the registered participants are higher, but the patients who have definitive diagnosis are less as compared to all the patients who are symptomatic, and there still remains a number of patients who are remains undiagnosed because of the non-availability of the specialized testing in most of the hemostatic labs. This third aspect is the genetic counseling. Already have been talked about so much. Genetic counseling, I think, or genetic diagnosis has some hurdles in our country because of religious and cultural sensitivities. But with proper counseling, and we can appreciate, and we can make the parents to go for the genetic diagnosis if they have a bleeding disorder in their families. Another aspect is the regular replacement therapy. Obviously, these patients require factor concentrate throughout their life, so we need to make provisions to provide them the factor concentrates uninterruptedly. And as Shabneez has mentioned, that prophylaxis is another thing through which we can improve the quality of life. And before the patient starts bleeding, we shall start with the prophylaxis in a child who is less than 3 years of age. Although the international guidelines that does not recommend the use of plasma or cryoprecipitate for the prophylaxis, but I think for underdeveloped or the developing countries like ours can make use of cryoprecipitate, and taking the reference from the neighboring countries like Egypt. The recommended prophylaxis dose is quite high, like 15 to 30 IU per kg thrice weekly, but low dose has been tried in a study which has been conducted in Tunisia, and they have used a prophylactic dose of 10 to 15 IU per kg thrice daily, and they have showed a significant number of less bleeding, and in turn it improved the quality of life because there was a low school abstinence in all those children who were on prophylaxis. So I think we can use a low dose of factor concentrates for prophylaxis, and we can also consider cryoprecipitate as well. So, with the aid of World Federation Haemophilia, more than 30 million IU or units of anti-hemophilic factor have been distributed in Pakistan since 2005, and in 2018 alone, almost 6.5 million units have been given to Pakistan. And because of that, the percentage of children who were on prophylaxis has been increased up to 60% in 2017. So this is an important aspect for us, where we can we can collaborate with the international societies who could help us, and not only in sharing of the knowledge, education, but they can also help in provision of these factor concentrates free of cost that would improve the quality of life in our patients. So management of inhibitors, obviously our aim is to avoid the development of the inhibitors by introducing early prophylaxis, but almost 20 to 30% of the patients are reported in the literature who develop the inhibitors within the first 50 exposures, and a single exposure is defined as the factor concentrates that were given within the 24 hours. The surveillance and the close surveillance for all those patients who are on regular factor concentrates, they should be screened for inhibitors, and we need to have the availability of the bypass agents, especially factor 7 and FIBA for those who do not respond to the higher concentration of factor 8. And obviously the immune tolerance therapy is the only effective therapy for inhibitor eradication, but it has its own limitation that has already been discussed by the prior speaker. So because of these reasons, I think we need to look for the alternative options because cost is an important issue which has been identified and that limits the immune tolerance induction. Musculoskeletal management, all these patients suffers through musculoskeletal complications because of the inadequate factor replacement therapy. So what we can do is we can make every possible effort for the early detection of the musculoskeletal complication, and what the hemophilia care worker or the physicians can do is to at least measure the annual joint bleed rates or annually apply the hemophilia joint health score system for assessing the health of the joints in these patients. And this is the recommendation by the World Federation of Haemophilia that recommends that annually we should have the annual joint bleeding rate and hemophilia joint health system scoring, and then the functional outcome can be assessed through X-ray or the point of care ultrasound of the joint to assess for the bleeds or the arthropathies. Emergency care and comorbidities is another important aspect because with the provision of these factor concentrates that are readily available now, the life expectancy of these patients have increased, and obviously hemophilia is one thing, but the other non-communicable diseases that are acquired with the advancing age like obesity, hypertension, cardiovascular diseases and osteoporosis are also commonly seen in patients, and hepatitis C is another issue in these patients. So we not only these patients require management of the bleeding symptoms, but these issues are also important, and what we can do for them is we can advise all these patients to carry these identification cards with them, because not every center in Pakistan has the treatment or diagnostic facility for these patients, because these patients are some of these patients are from remote areas of the Pakistan. They do not have readily readily available access to the big hospitals. So what we can do is we can give them the identification card mentioning their diagnosis and how the type of the severity of the disease, and how the emergency or the life-threatening bleeding or the minor bleeding can be managed in these patients. And that's why we always give our patients who have hemophilia a one-pager history, and we ask them to keep it with them in their wallet, and whenever they go to the hospital, unexpected visit to the hospital, they can show it to the doctor over there. This is a simple. This is another slide which shows how the innovation has been there in the management of the hemophilia. And if you can see over here, in 1960, the treatment was really started with cryoprecipitate, followed by the introduction of the intermediate purity concentrates, and followed by the desmopressin. But then in 2000s, a single purity high concentrate were introduced. In by 2010, extended half-life concentrates were available, and then in 2020 and onwards, new factor therapies, including gene therapy, has been introduced. So these are the newer modalities which Dr. Munira is going to talk about, but gene therapy has shown promising results, because in phase 3 clinical trials, a single injection of this in patient who received the single injection, they did not had any bleeding symptom for about 2 years. But obviously the cost is an issue with this thing, but I think the results are very promising. And also the availability of these monoclonal antibodies that affect the different coagulation pathway and which eliminates the need for factor 8 concentrates are also promising. And I think we are going to listen more about it by Dr. Munira Borhany. So with this, I come to the conclusion of my presentation. Obviously, there is a long list of the principles that of hemophilia care that we need to be mindful of, but it starts with our education and training, and then quality assurance in the hemostasis lab. We need to have referral labs for the genetic testing. We don't want to, for especially for the genetic testing, the concept is less is more. We don't want to have the referral centers in every town of our country, but I think 2 to 3 genetic labs or the referral labs where we can screen for the genetic defects would be optimal. And regular assessment for the patients, for the inhibitors, for these skeletal complications and comorbidities, and obviously collaboration through partnership and research for acquisition of novel therapeutic modalities is also important. Thank you.
Thank you so much, Dr. Anila, for that elaborate discussion on the general measures that need to be for these patients, especially the identifiers part where, we need to provide them a letter or a card which they need to carry all the time if they land up in the hospital for any reason. So we'll talk about treatment options.
Right. So, thank you so much for the opportunity. It's always nice to talk about hemophilia at all times. Right. So, this is my talk on treatment options on hemophilia. Okay. So now, don't tell me. Okay. Please, I have no conflict of interest. This is how we will go about this talk. We'll talk about the available treatment options in Pakistan. We'll talk about the goal of treatment, the role of factor concentrates, how to monitor it, what's the prophylaxis, what else can we do for these patients regarding physiotherapy and joint health, what about oral bleed, is there something new, and of course, the game changer, gene therapy. So where do we stand? Currently in Pakistan, there are 4 societies which are made of hemophilia patients. There's one in Karachi, in Peshawar, in Lahore, and Rawalpindi. The reason I'm talking about these societies is because this is where the treatment is coming from. Despite being a small chunk, it's still coming from there, and we are talking about extended half-life factor concentrates. So this is how it is. We have 4 chapters. There are more chapters coming up, and I think Dr. Ayisha Imran would be more than happy to talk about it. But Haemophilia Foundation Pakistan is a society that actually manages the whole treatment stuff. Right, so what happens to our patients in Pakistan on a majority basis? This is how it starts. They go to one hemophilia treatment center, then they end up on another hemophilia treatment center. Somewhere they can get plasma factor concentrates. In other places they might not. So they're getting actually a component of both factor concentrates and plasma transfusions. What do we have here in Pakistan? We have concentrates, but it's plasma derived and it's coming through parallel trading. And we have tranexamic acid, we have desmopressin, although not mentioned here because it's not given that much on a routine basis. Maybe I don't know about it, but desmopressin is here, not given on a routine basis. Bypassing agents, yes, we do have Novo 7. Okay, so we do have Novo 7 and we do have different bypassing agents coming through parallel trading. We have FIBA, then Emcizumab, which Dr. Munira is going to talk about it in her presentation. This is a bispecific antibody and it sort of bypasses factor 8. And then we have cryoprecipitate, cryosupernatant, and fresh frozen plasma. Of course, with the advent of regional blood centers, we have loads of it. Okay. So what is the goal of treatment? So one major goal, a very common clinical presentation, we need to prevent joint bleeds. And this is talking about the majority of it, because 80% of them, 70 to 80% have joint bleeds. Rest of them can come up with any emergency bleed, such as GI bleed, CNS bleed, any bleed that can be an emergency. But the commonest clinical presentation is joint bleed, which majority of the medical officers and doctors will see in their clinics. What is needed? We need diagnostic facilities, we need prophylaxis, we need prompt treatment, and we need family screening to detect carriers, oral care and counseling. So basically we need comprehensive care. So what is the model of comprehensive care? Of course, this is how it is all formed, and this is actually a dream if this happens. So a hematologist, a nursing coordinator, an orthopedic surgeon, a physiotherapist, multidisciplinary care. If these patients suffer from anything that's besides a joint bleed, we need a radiologist, and the most important of all, we need a psychosocial expert. Now, what do we do over here? So we actually follow World Federation of Haemophilia guidelines for hemophilia treatment, and these are guidelines for resource limited. And I always say now we need to start thinking of being non-resource limited. We need to create our own resources. But this is how it is. If you look at it in hemophilia and hemophilia B, there is a slightly lower level, desired level of treatment in terms of your target factor level. So it's slightly lower as compared to a developed world. That's because we don't have it. But if we have plasma at our disposal, we can always merge it with factor concentrate and give the patient desired dose at the level of that which is being done by the developed nations. So we can do it, although I've shown the resource limited setting protocol here. So what is new? What is new are the extended half-life products. So we are all aware, we have a lot of hemophilia physicians in our setting in Pakistan. Lots of them are treating. So we are all familiar with plasma-derived factor concentrates. So in plasma-derived, for factor 8 you need to give a 12-hourly dosing, and for factor 9 you need to give a 24-hour dosing. But now, because now the goal of treatment is improving the quality of life of these patients, and of course to give them some prophylaxis at some point in time, people have come up with extended half-life product, and this is how they have done it. They have pegylated the factor 8 molecule, they have created FC fusion molecules, they have fused it with albumin just to prolong the half-life of these factor concentrates. So what happens because of these? The dosing frequency decreases, the compliance increases. Excellent work is achievement is the increased trough levels these patients get as a result. And of course, less dosing frequency means you can manage these patients on a much better platform, because you don't need to keep on repeating factor 8 levels and factor 9 levels very rapidly, which we are always doing even as residents, right? So this is something very nice. And yes, eloctate, if you look at the chart, you will see eloctate, you will see adenovate, and you will see alprolix in factor 9, and these are all being supplied by the World Federation of Haemophilia. This is how these societies help us in treating our patients. Now the inhibitors are it's bad news basically. So if I know if my patient has inhibitors, I'll go in a red zone, because inhibitors are very difficult to treat and they're very expensive to treat. So we divide inhibitors into two categories, and this is as simplified as it can be. You get an inhibitor screening done, and you get a Bethesda assay done. And if the Bethesda unit is more than 5, these are high titer inhibitors. No matter how much factor 8 you give these patients, it's not gonna go away with the factor 8 dose. So for these you need bypassing agents, and these bypassing agents are factor 8 bypassing agents, FIBA, and you have of course recombinant factor 7. For low titer inhibitors, this is where the high dose factor 8 works. But now the extended half-life factor 8 is coming up, and so maybe it's gonna work in inhibitors if we give high dose in low level of Bethesda unit. We don't know, but yes, now we are talking about emcizumab as a bypassing agent, and things are coming up. Would it work if in a patient who has had inhibitors? That is a question which remains to be answered. For now, emcizumab or bispecific antibodies, these are all prophylaxis based. and maybe treatment. This we will know in the upcoming talk. Now, immune tolerance. So, when somebody tells me we are doing immune tolerance induction, I go like, okay, where is the factor 8 coming from? So we need a lot of factor 8 to actually come to this part, and it's like a long treatment. What we do instead is try and not let the inhibitors develop, because this is so expensive. So yes, it works, but it takes a long time, 12 months to 2 years. It's highly expensive. Now, coming on to monitoring of factor therapy, so what's new? This is what the talk is about. What's new? So WAPS Hemo is something which is freely available. Now that there are doctors who have extended half-life at their disposal, they need to know, even for plasma derived, they need to know how these factors, because every patient is coming up with with their own pharmacokinetics. So this is software. I'll talk about this. So what is pharmacokinetics? You need to know when to give the next dose of factor 8 or factor 9. So this actually tells you the time. After 2 to 3 samples of patient, it will tell you what is the time of your next dose of factor concentrate. So this is it's a very good software. You don't need a lot of information to put in this software, and it actually tell you that after a single infusion, what is the level of factor 8 that is reached, that is still there in the bloodstream. What affects pharmacokinetics is the weight of the patient, the age of the patient, the disease severity, and the blood group. WAPS Hemo is web-based. If you go on Google, you can write WAPS Hemo. It will give you a website, and you just go there, put in your patient's information, and then it will give you the whole dosing frequency. So it's web-based, and you need 2 to 3 samples of patient to put in the software, and that's where it will give you the information. And it's totally free. This is how the report comes, and if you see on the right side of the report, it will tell you at what pre-dose level, what was the pre-dose level, and what happened after you gave these patients multiple dosing. So it went on to 0.070 at this point in time. So in 1 hour, this was the level of the factor. So it will tell you everything. And now I think worldwide over 29 countries are now using WAPS Hemo, and Pakistan is not on the map yet. So I think this is a good platform to actually think about starting it. So prophylaxis, very important. And I would always say, if you don't have factor concentrates, maybe you can do it with a good NAT tested plasma. So it can be done. Prophylaxis are different kinds, but what we see commonly over here are patients coming up in the tertiary phase or the secondary phase. What we are aiming for is the primary prophylaxis before the second joint, but unfortunately we are getting patients after second joint, or those who have terrible arthropathies. So prophylaxis is very important. Now what is our hurdle over here is the amount of factor 8 or factor 9 which is required for prophylaxis. So now, if you know that there are different protocols. So we are talking about developed world and the developing world. So Egypt is always, I say, it's a successful model. So it published multiple papers on prophylaxis, and it is worked up its minimum dose. And what they are doing is they are giving cryoprecipitate. Even with their SD method, they are giving SD treated cryoprecipitate to the patient. So I think it's now high time. I'll just leave this in an open question. What can we give our patients for prophylaxis? Can we achieve this target dose of 30 international IU for let's say 2 to 3 times per week? Maybe we can. Coming up to physiotherapy and joint health, highly neglected. Oral bleeds and physiotherapy, joint health, 2 things which are highly neglected. But you will see patients who have actually, these patient societies, they are big on counseling their own patients in going for physiotherapy and maintaining a good joint health. So this is where the problem, I think, starts, because of the poor joint health and the osteoporosis, and now coming up to pain management. So pain management, this is where another the bad quality of life starts, because in pain management these patients are usually on paracetamol or they are on tramadol, but they don't get those NSAIDs. Celecoxib is a very proven thing. It's been given in the developed world, and this is a second stage of managing pain management. So if you give these patients celecoxib for a week or 2, it's not only gonna work on their pain of joints, but it's gonna actually all the neovascularization that's going on in their joint. It's gonna work on that. It's gonna uh, decrease the neovascularization in their joints, which are actually the bleeding points in the joint bleed. So celecoxib is something which I have actually tried, and it works like magic, but not for a long period of time, because you need to ensure that the patient does not have hypertension, and the patient's creatinine is normal. So these are the two things we need to take care of, and most probably the patient will not need morphine. So, chronic arthropathy, yes, chronic arthropathy develops, and then we get acute on chronic joint bleeds. This is how they are managing. They means now almost half of the world, more than half of the world is going on towards these trainings, these point of care joint ultrasounds. And if you can see on the image, you can see all the colorful things on your image. On the right side of the image, this is where all the neovascularization is happening, and this is where they decide whether to give NSAIDs, whether to refer to an orthopedic surgeon, whether this patient actually has a bleed or not. So this is a very important tool, and I think every hemophilia treatment center should have one. This will not only save resources, but this will also work on identifying the cause of joint pain. In oral bleeds, again, these patients are very poorly counseled. Majority that oral bleeds are not that important for the doctors, but the joint health is apparently more important. But when you see when you look at your data, these patients around 60% have mucocutaneous bleeds, and this is because of their poor oral health, which occurs at the time of diagnosis. So the ideal way to go about it is, when the patient comes to you at diagnosis, which is usually childhood, you can always tell the patient that you need to have at least one annual checkup by the dentist, and of course every regular thing that that normal patients are being counseled. These are again very normal patients. We always should counsel them for oral health. Intractable joint bleeds can not only lead to joint reduction, and it's a terrible thing to control, and people have had to undergo surgeries, dental surgeries. What the new thing in this in the new treatment option in oral bleeding is laser therapy. So the dental part of the WFH has a team which actually talks about laser diodes, and if the patient comes up to the clinic and if they see this intractable bleeding, it's not stopping, so they just do a laser in the gums, and this is how they freeze the vessel. So a lot of you are going to talk about, okay, it's laser and it's gonna that the patient is going to bleed afterwards. So it doesn't happen apparently. They do laser therapy, and then the patient actually, at that point in time, the joint bleed is controlled. Now the last part of the talk is gene therapy. Gene therapy is very upcoming. It's the most talked about topic now in hemophilia as well as thalassemia. So what happens in gene therapy? You introduce normal genes in the cell, and you correct the defective one. So genetic disorders are treated that way. Single gene defect is a defect in the factor 8 or factor 9 gene, and factor 8 gene is very big. It's a very large gene. Factor 9 is a smaller gene. So the success in factor 9 was seen earlier than factor 8 gene, and the goal of these gene therapies is to increase the plasma level above 5%, but now the latest thing which is coming up is 1%, because if you convert this patient from severe phenotype to moderate phenotype, this is enough. So the good news is, and this is the light at the end of the tunnel, I would say, is that the first gene therapy approval for hemophilia A, apparently not B, but for A, has been approved, and it's called BioMarin's Roctavian, and it's been approved for treatment. It's gotten FDA approval, so that's good news. Somewhere we are reaching somewhere after so many years of talking about it. So to summarize, yes, we have very limited treatment options, but as you can see, there are a lot more options coming up, and it's all can be made available in our setup. And counseling is a very important part, and yes, we should all think about gene therapy now. Thank you so much.
Thank you so much, Shabneez, for an excellent overview, especially the part on gene therapy seems very fascinating and promising. And I'm sure we will have questions when the webinar is over. So with that, I'd like to remind everybody that if you look at the bottom of your screen, there's a question and answer tab. Please post all your questions there, and we'll take them after the end of the session. With that, we come to the last talk of the webinar, which is innovative and upcoming treatments present for hemophilia, and Dr. Munira Borhany, consultant hematologist from NIBD, will speak on that.
Okay, thank you, Natasha, and thank you, PSH, for giving me this opportunity. It's always wonderful to talk on hemophilia, and especially on the platform of Pakistan Society of Haematology, where so many colleagues and so many residents and so many treating physicians are there with us and listening to hemophilia and other bleeding disorders. The topic assigned to me is emerging therapies for hemophilia. As all, I have nothing to disclose, and as already has been told, that congenital hemophilia A and B are inherited bleeding disorders caused by the deficiency of the coagulation factor 8 and 9 due to the mutations in the gene respectively. Now we have the recombinant and the plasma-derived factor concentrates, which are the major chunk for the treatment of hemophilia and are the standard of care for these disorders. This figure shows the historical timeline, the research and development which has been done for the treatment of hemophilia. And you can see in the 19th century started with the blood transfusion. And gradually came the discovery of the hemophilic factor in the cryoprecipitate, then goes on the purification of the factor 8, then the how to improve the half-life of factor 8 and the factor 9. And now we have multiple products available to us for the treatment of hemophilia. This slide also shows the major advances in the therapy of hemophilia and the associated outcomes. Main important thing is the important supportive care for the hemophilia in a hospital or a clinic-based care to treat the bleeding, especially the joint bleeds, because the joint bleed is the main bleed in the hemophilia beside other bleedings from other sites like the oral cavity bleed, the mucocutaneous bleeds, the circumcision bleeds, and especially in the females, the menorrhagia. We have to replace the missing clotting factor to prevent the bleeding. For now, we are coming to the home-based therapy to minimize the time. With the treatment, we always have a challenge of treating the patients with the inhibitors, and these inhibitors and the other transfusion-transmitted infections and other things reduce the morbidity and the mortality. Now we have the non-replacement therapy for our patients, which are effective for the treatment and its prevention. And we are also using in Pakistan as well. And the upfront is the gene therapy for the treatment and of these disorders. So now we have the extended half-lives available to us, which increase the half-life of these products to improve the quality of life of patients and its prognosis. These extended half-life products extend the half-life of the products, especially by doing the different modifications, the chemical modifications, which includes the albumin and the constant region FC. These bind to the FC receptors and they increase the half-life. They are approved and are licensed for the clinical use. Another important modification is the pagylation, which is done in these factors to increase the half-life. We have different extended half-life products available to us, which have the limitations because they are all IV administered, and there is no lack of comparison between the different extended half-life products. The two extended half-life products, which includes the eloctate, factor 8 concentrate, and the factor 9 concentrate alprolix. These both factor concentrates are available to our patients which are being treated at the Haemophilia Welfare Society of Pakistan, and we have the low dose prophylaxis available to our patients with these factor concentrates. So it's have a good experience of using the factor 8 and factor 9, and the most important thing is that we use low dose prophylaxis as recommended by the World Federation of Haemophilia, which is 10 to 15 IU per week. For factor 8, we use twice a week. For factor 9, we use only once a week. Now we have the coagulation mimics, which are the emicizumab. The emicizumab is also available to us through the World Federation of Haemophilia. And the important thing is that we don't need a laboratory testing for it. And because the coagulation factor, the coagulation based, the tests are affected by these, and we use and for the emicizumab, we need a chromogenic assays, which are not available to us. And the primary endpoint of these are the bleeding events. So in short, they have improved the efficacy and the standards of factor concentrates, and patient experience the limited bleeding episodes with this. The emicizumab is a humanized biphasic monoclonal antibody, which activates the factor 10, which is a bypassing agent basically, which directly activates the factor 9 and factor 10, and bypasses the factor 8, and it maintains the hemostasis in hemophilia A. It is used as a routine prophylaxis in patients of hemophilia, whether it's adult or peds, in inhibitors as well as without inhibitors. It has long half-life and it is given subcutaneously. The regimen used for the emicizumab at Pakistan at World Federation of Haemophilia donated us, and we have enrolled 36 patients in this, and the loading dose is 3 milligram per kg, which is given once weekly for 4 weeks, and the maintenance dose is 6 milligram per kg, which is injected for 4 weeks after once monthly. So 36 patients of severe hemophilia A are recruited at Haemophilia Welfare Society, Karachi, which is connected with the Haemophilia Foundation of Pakistan and receiving the emicizumab through the World Federation of Haemophilia. And these are the enrollment criteria of our patients. The patients under 12 years of age with inhibitors are 6 in number. Patients more than 12 years with inhibitors are 13, and patients without inhibitors who have an annual bleeding rate of more than 8, past history of intracranial bleed, abdominal bleed, or pseudotumors are 5, and patients more than 12 years of age without inhibitors on a case-by-case basis who have a significant bleeding history were 12. And you can see from this chart the figure that patients, the number of hospitalization of these patients before Hemlibra and after Hemlibra. The total number of hospitalization before was 47, and after the treatment was only 1. The median, you can see the mean absent days from their school, from their work was 67.8 days before the treatment, and after treatment they are 0. So you can see that there is a marked difference in the quality of life of these patients there when they are on treatment. Similarly, the bleeding symptoms, the major bleeding or the minor symptoms have significantly reduced after getting the treatment. The annual bleeding rate also decreased from 66 to 0. The inhibitors were present in 33.3% of the patients before Hemlibra, but none has been reported after the treatment of this prophylaxis. Similarly, on demand patient, they were on 88.8% before treatment, and after getting the prophylaxis with the emicizumab, there are only 5.5% patients getting prophylaxis on demand. No a transfusion reaction, because all we know that with the plasma, we have a transfusion reactions. Majority of them get the transfusion reactions. But after the getting the treatment, as the treatment on demand also decreased, therefore the transfusions were also decreased and the adverse reactions were also decreased. The adverse reactions reported with the emicizumab were also only the injection sites were having the redness, the pain, headache, and rashes. We haven't performed any surgery before the emicizumab, but after getting on the prophylaxis, we have performed the dental root canal, the circumcision, and we were very excited that we did not have to use much factor concentrates on these patients because they were already on prophylaxis. Similarly, our patients on the joint score, you can see there is a marked improvement in their joints, which shows the median was 8 before the treatment, but after they were 30, means they were having an independent score. Their quality of life improved. They were very happy. And you can see that our results shows that the patients on Hemlibra or the emicizumab had a marked difference on the quality of life. Their joint score improved and their annual bleeding rate also decreased. So our results showed that the prophylactic treatment with the emicizumab were less restricted and improved quality of life, especially improved their health and social lives. Similarly, emicizumab was very well tolerated. No participant discontinued the medicine because of the adverse effects. Now, the other products which we have available, not available in Pakistan, but available internationally, is the phytosteron. Phytosteron is a novel therapy which is applied to both A and B, which consists of the amino acid and acetyl galactosamine, the ligand to the liver, which is conjugated to the synthetic small interfacing RNA. Once it enters and targets the serpine cRNA, prevents the antithrombin production. And enhances the thrombin generation. Thus, it imbalances corrects the coagulation imbalance and prevents the bleeding phenotype. Similarly, the other product which is available is the concizumab, which is a monoclonal IgG antibody, which targets the tissue factor pathway inhibitor, and it is used in both A and B. It binds to the epitope on the K2 domain and subsequently prevents the tissue factor pathway inhibitor, and which enhance the formation of the thrombin in the coagulation cascade and stabilizes the clot formation. This is the diagrammatic representation of the phytosteron, which shows the small RNA being injected and then inhibiting the antithrombin synthesis. Similarly, the concizumab antibodies, which are the monoclonal antibody, also targets the K1, K2, and the K3 domains and inhibits the coagulation pathway. The other thing is the gene therapy, which is very upcoming and being done, and is the clinical trial, and now it has got the FDA approval as well. The cloning of the factor VIII gene not only allows the generation of clotting factors, but also the gene therapy as a potential cure of the disease. This successful work has transmitted into the gene therapy for hemophilia, and all published and currently available, the trials have used adeno-associated viral vectors for the replication of this the gene, which is non-pathogenic to the humans. Thus, the vector genome is manipulated and replace the AV codon sequence with the transgene of the interest, which is made under control in the liver to promote the recombinant factor vector. You can see from this diagram that the recombinant adeno-associated vector genome is injected through the infusion, single infusion. Then it is again these are neutralized by the antibodies. So then they in the liver, they are transduced with the capsids. The capsids are removed and then they produce the protein in the liver. And in this way, the factor levels are increased. So the current data shows that the gene therapy trials seem to confirm the expression of the heterogeneous factor, which are equivalent to the endogenous factors, and the factor replacement is there, and we change the phenotype of the patient, and now we are talking about the cure of the disease. But the data is still more data has to come to see this, the results of the upcoming gene therapy and its adverse events, because some adverse events has been reported, like the raised in the ALT levels and the mild side effects. So in summary, we have now emicizumab available to us, which is a biphasic monoclonal antibody, which is used in the hemophilia once a week in the loading dose and then once a month as a maintenance dose. And we have seen and ourselves treating the patients in Pakistan with a very good results of these emicizumab. Similarly, the phytosteron, the concizumab, and now the gene therapy are the things which are upcoming for us in the hemophilia treatment. Similarly, there are multiple studies and the available things in the recombinant factor 9 concentrates which are available, where the main thing is to increase the half-life of these products. So we have minimum infusions and the quality of life of these patients are improved and get compliance to their treatment. So in summary, I would say that the awareness, education, and the genetic counseling is needed to prevent the spread of such common occurrence of these bleeding disorders in our community, because hemophilia is a very treatment-wise, very expensive disease. Patients are not diagnosed properly. And when they are not diagnosed properly, they come to us with all types of complications, especially the joint bleeds. And the joint bleeds are so much that we cannot go back and prevent them. So the current factor replacement therapy is the main standard of therapy to increase the treatment and the quality of life. However, the inhibitor development presents a key limitation to factor replacement. And when the patient develops inhibitor, it's a challenge for the physician how to treat it without the factor concentrates available to us. The extended half-life products, that is emicizumab, phytosteron, and the concizumab, appear effective in patients with or without inhibitors because of the long half-life and less frequent injections. Now we have gene therapy, which has produced the promising results, and the upcoming literature shows that very long-lasting endogenous factor production is there in these patients. Despite the high efficacy and promising outlook of these therapies, the conventional factor replacement remains the most prevalent hemophilia treatment modality. Especially in Pakistan and the other resource countries, the access to the factor replacement is still greatly limited. Thus, the introduction of new and sophisticated therapies with higher cost are likely to be inaccessible to the large proportion of hemophilia patients globally. The novel therapies offer an arsenal of treatment options and could revolutionize the future of treatment. However, we need a proper infrastructure facilitating the worldwide availability of these factor concentrates, which becomes a barrier to treatment, especially in countries like Pakistan. Thank you so much. And I would be happy to take any questions.
Thank you so much, Dr. Munira, for that excellent overview of the newer treatment options. And with that, I will open the floor up for questions. So we have quite a number of questions in the chat box. And Dr. Shabneez, I'm going to start off the first question with you. So the question is, can you please comment on the Egypt experience of using cryoprecipitate as a prophylaxis tool in hemophilia A? That's the first question. And with that, would you also like to tell us how has your experience been with the use of cryoprecipitate in patients with hemophilia A?
Right, so I'll start with Egypt. What they are doing is they are using, let's say they're giving cryoprecipitate to their patients as prophylaxis. The only difference is the volume is reduced and they are SD treating it. So they are creating mini pools of cryoprecipitate, and they are they are making it 0% risk for TTI, and then they're giving these as mini pools to their patients, and the storage is like it has to go in cold storage. So these vials are given to the families of the patients to keep in their homes, and then they also teach them home treatment for prophylaxis. So this is like a whole cycle, and they do not have factor concentrates. The only thing which we need to know is that it's not factor concentrate, it's actually cryoprecipitate, and it's just lesser volume, 100% ATI. The experience of prophylaxis with plasma with me personally, I've not used it, and that's, I think that's the only drawback I'll say for myself, that I did not use it, and it could be considered, but for me, I would say it has to be at least net tested, so that we are not transmitting any TTI to these patients by giving them plasma on this much of a regular basis as we give prophylaxis.
Thank you, Shabneez. Dr. Anila, couple of questions for you. And since Dr. Ayisha had to log off, I will ask these questions. These questions will be directed to you. So the first one is, how do you deal with a carrier female who comes to the clinic at the first visit when she's pregnant? So the booking visit of the pregnancy. How do you deal? I mean, I'm sure they're asking about the counseling. And if genetic testing is not available freely, which is the case with quite of the labs here in Pakistan, how do you diagnose a patient with carrier for hemophilia?
Thank you. Sorry, there is some issue with my video, so I think I'm audible to all of you.
Yeah.
Okay, so the first question was how to identify the carrier and how do we manage it? Well, in my clinical practice and experience, most of the times we don't know about the carrier status of the females because they are never been tested. But if they have a strong family history of hemophilia, we consider such women as a carrier and we do the counseling accordingly. Obviously, during the pregnancy, the carriers do not have any problems as such, but it is the baby who is at risk. And obviously, if we know the gender of the baby, we counsel them accordingly that if it's a female child, then you don't have to worry about, but if it's a boy, then there will be a risk of the child being born with hemophilia. Then we remain in close contact with the OBGYN who is dealing with that patient, and we give them a detailed delivery plan, what would be the mode of the delivery, whether obviously the carriers are not going to bleed as much, but if they do, we do have the factor concentrates, but it's the baby who needs the testing. And if there is a hemophilia A in the family history, it can be diagnosed at birth because the newborn has normal levels of factor VIII at birth, so it can be easily diagnosed. But we do tell the gynecologists avoid the traumatic delivery, avoid using the forceps or the vacuum to avoid any head trauma to the baby. So this is how we counsel them. And I think the second question was about the availability of the genetic testing. Yes. So I don't think that we do have the availability of the genetic testing in Pakistan, and if there is any, I don't know about how validated the assays are. Yes.
Sorry.
Yes. Okay.
We have an NIBD available.
Okay.
We screen for the genetic testing of the hemophilia and for the rare bleeding disorders.
Yes, and I think there are certain limitations with the diagnosing the carrier status, because because most of the time the females say, even if we find out that we are carrier, and even if our baby is carrying this disease, we are not going to opt for the abortion and all those things. So keeping all these things in mind, and the cost which is attached to diagnosing these carrier status is something that we need to consider. At AKU, we do have collaboration with the international labs. We can send the samples over there and they can test it for us, but obviously the patient needs to pay the cost for it. Thank you.
Thank you. Dr. Munira, so the next set of questions are for you. So the first one is for the low dose prophylaxis that you talked about for the extended products for factor VIII. Do you use pharmacokinetics, or if not, then how do you monitor the treatment?
For the low dose prophylaxis, we check the factor VIII levels, and we maintain the factor VIII levels are above 2% for the factor VIII. And we have checked it, and we have done this with a couple of our patients, and we monitor them clinically as well. And so we are very happy that the results are very good for the extended half-life. And for factor VIII, we are using the low dose prophylaxis because it's provided by the World Federation of Haemophilia. And we have enrolled a couple of patients, 25 patients are there on low dose prophylaxis at Haemophilia Welfare Society, Karachi.
So Dr. Shabneez, would you like to add anything to that? How do you monitor, how do you monitor the extended health?
Yes, so ideally the software I was talking about, this is the kind of software people are actually using, the WOP software. And all you need to, because the question was on pharmacokinetics, right? So I
Yes.
don't know if Dr. you're measuring you're doing it according to pharmacokinetics, or you're using what I'm understanding is you're using the guidelines, the regular guidelines for what dosing to give and how to give it. But pharmacokinetics is something very new and it can be done, and all you need to do is like add the basic demographics of the patients. I don't think, Dr. Meena, are you using the WOP software for
I'm
that?
using, no, I'm not using that software, but I use the trough levels of injection factor VIII, and I monitor that levels after giving the injections. So I monitor the levels of the factor VIII.
Yeah.
Right. Okay. Next question, Dr. Munira. How do you manage the breakthrough bleeds when patients are on emicizumab?
I manage the breakthrough bleeds with the factor VIII concentrates if they are without inhibitors. But if they are on inhibitors and have the high titer inhibitors, then I use the RO7 or factor 7.
Right.
I don't use the bypassing other agents because they are not available to us. The problem is that.
Right. Has the experience been good with this drug, emicizumab in Pakistan?
Yes, very good, very good. I've shown my results. You can see from their results that they improve the quality of life. All the annual bleeding rates and the bleeding symptoms markedly decrease. So I think it's a game changer, and all my patients are very happy with this medicine. And more patients need to be enrolled, but we don't have the access to this medicine, so it's very limited. I hope in the future we get the more drug available to us so we can enroll more patients in it.
Right. So last question before we close, Dr. Munira, you had shown the data on Hemlibra. So the question is, what was the follow-up time before the patients received Hemlibra and after that? That one data that you showed on the efficacy of Hemlibra, what was the follow-up time between the dosing before enrollment and after looking at the effect?
Yeah, and following them every monthly, because after the loading dose, when they come to us for the injection, we have developed a performer at the Haemophilia Welfare Society, Karachi, and we ask all the questions related to their bleeding, related to their quality of life, their joint score. We have a physiotherapist available at the Haemophilia Welfare Society. So she assists all the joints and monitors. So it's a monthly assessment basically. And we have now collected the 6 months data. And I think it's now more than 6 months that we are on emicizumab now.
All right. Thank you very much. And that brings us to the end of all the questions. I hope I have taken up all of the ones written in the chat box. Thank you to all the participants who have joined us on a Saturday for this webinar. Please remember that this is going to be available on the PSH website and our Facebook page. Thank you to all the speakers for taking out the time to do this for PSH. We are very grateful and thankful. And hopefully we will be coming up with a couple more webinars next year before the HemeCon conference. Thank you very much and Khuda Hafiz.
Thank you.